Hi, everyone. Thank you so much for joining us for OSPF's February webinar. Our topic today is PANS and PANDAS, Symptoms and Solutions, an overview of diagnosis, treatment, and mental health safety. My name is Emily Steinberg, and I am the Communications Coordinator here at the Ohio Suicide Prevention Foundation, and I have the privilege of hosting today's webinar. I'm really excited to welcome Gabriella True with ASPIRE, which is the Alliance to Solve PANS and Immune-Related Encephalopathies. Hopefully I didn't butcher that. But before we get started, I want to go through some quick housekeeping items. So after today's webinar, we're going to send a follow-up email. This email is going to have a lot of information in it. It'll have the post-webinar survey in it, which you will need to fill out if you would like to receive CE credits or a certificate of attendance. And then CE credits are going to be available only to our OSPF members. So I will send a link for membership if you're interested in signing up to get CEs from our webinars every month. Also in that email, I'm going to include a recording of this discussion if you want to pass it along to anyone, and the presentation slides that Gabriella is going to share. And then at the end of the presentation today, Gabriella is going to open it up for some questions. So please put those questions in the Q&A feature throughout the conversation today, and I will keep track of those. And Gabriella, I'll moderate that section for you. But I do just want to note really quick, we have a lot of folks in the room today, which is so wonderful. And Gabriella has a presentation chock full of incredible information. So we may not get to every single question. And if that is the case, Gabriella is available for follow-ups afterward, and I will send her email. So without further ado, let me introduce today's speaker. Gabriella True is the president and a founding board member of ASPIRE, which is a national nonprofit focused on awareness, education, and support for individuals with families affected by PANS and PANDAS. Under her leadership, ASPIRE delivers programs and resources for patients, families, schools, healthcare providers, and policymakers while advancing education, advocacy, and policy change. With over a decade of experience in PANS and autism communities, Gabriella has helped shape state and regional initiatives. She also co-founded the Connecticut PANS PANDAS Partnership, served as president of the New England PANS PANDAS Association from 2015 to 2018, and was a member of the PANS PANDAS Advisory Council to the Connecticut Department of Health. She also volunteered for more than 10 years with the Autism Community in Action, and as a mother of two young adults with PANS and an adult patient herself, she brings both lived experience and professional leadership to all of her national advocacy work. Gabriella, thank you so much for being here. I'm going to turn it over to you and we can get started whenever you're ready. Oh, I believe you're still muted, Gabriella.
Oh, that
There we go. All good.
if we could ever learn how to do that automatically. Thanks for having me here today to speak about PANS PANDAS. It's going to be a very fast overview of symptoms, diagnosis, of treatment. It's filled with a lot of information, but like she said, we'll try to get to questions. I might get to one. Um, Anyway, so this conversation about suicide thoughts and behaviors is really incredibly important, and it's important to start thinking about those symptoms happening very early on so that we're not caught off unaware going, oh, that came out of the blue. So we're going to talk about this disorder in a lot of detail today. I have nothing to disclose. Our learning objectives, like she said, she's going to send off the links for the credits after. We're going to describe the PANS diagnostic criteria, identify key concepts regarding disease course, severity, common triggers and disease mechanisms of PANS PANDAS, and provide an overview of diagnostic treatment approach of PANS. So where are we starting? We're going to start with the fact that medical conditions often present first with neuropsychiatric symptoms. They may have some medical conditions but we're not noticing them. We see the psychiatrics up front. But what we really need to be looking at is that underlying cause. So we see that these psychiatric conditions in various primary vasculitis and secondary vasculitis, different types of autoimmune encephalitis or diffuse cerebritis. But today we're really focusing on what's happening in the basal ganglia and very specifically PANS PANDAS. So if we start with the idea that a medical condition can look completely psychiatric in nature, especially at first glance. And we want to think about what are we going to diagnose this patient with? And we start to go through the DSM because we're thinking psychiatric only. What part of that criteria and that differential diagnosis is sorely under investigated is the ruling out an etiological medical condition. And as we gain more and more research, plenty more has to be done. But since COVID and with what we know about tick-borne diseases and now what we know about PANDAS and autoimmune encephalitis, we have to really understand that there's medical health and mental health are not separate issues. Our brain is not detached from our body, sort of hovering 10 feet down the road and having nothing to do with happening in our body. So even if it's not the full reason that we're having the psychiatric symptoms, we always should be looking at what's happening with the body too and ruling in a medical issue. But in PANDAS, it is the underlying cause. So when we're going through a patient's history and current systems, we don't just give them a label to give them a label and send them on their way. What are we doing with that label? That correct diagnosis drives appropriate treatment. But if we do not get to the correct diagnosis, then we're not going to get to appropriate treatment and we're not going to get to ultimate healing. So correct diagnosis is critical. Some of the treatments may overlap, but some of the treatment approaches can differ significantly. So we don't want to miss it. It's really, really critical that we take the time to do this correctly. So going into PANS and PANDAS, with this in mind, that we are looking at this underlying cause for these symptoms. So what do we see? It is a clinical diagnosis. There's not a single test or anything like that. Yeah, we can use labs and all of that. That can be a part of it, but it can also inform how we're going to treat, what are we going to do. So it's a syndrome. So pediatric acute onset neuropsychiatric syndrome. What is a syndrome? A syndrome is a description of a cluster of symptoms that happen at the same time. It doesn't speak to the hows and whys. It's really like Tourette's. It's a syndrome. It describes the symptoms that are happening together. So in PANS, those specific symptoms are obsessive compulsive symptoms along with and or severe eating restrictions, along with other concurrent cognitive, behavioral, and neurological symptoms. Trust me, I'll go into them in a lot of detail. If they have multiple triggers and probably multiple disease mechanisms depending on what that trigger is. Whereas PANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection, a little bit of a tongue twister, is a subset of PANDAS. It is a disorder. We have those symptoms and we know that proximity to strep. They don't have to have strep throat, but we have to have a temporal relationship to group A strep. And we know basically the disease mechanism. Like any other disease and disorder out there, there's always more research to know, but we know what the mechanism, which we will go into. So let's start at the criteria. So the first part, abrupt acute onset or worsening of. Before we go into the worsening of what symptoms, let's talk about what that means for a moment, because it's really, really important. So if you read a lot of articles that are out there, they will absolutely hammer in the idea of very, very sudden. And yes, we do have plenty of patients and plenty of families who know the date and time everything changed. But what we know from very in-depth characterization research, like one done by Stanford several years ago. We know that about 40% of the Stanford cohort, they have a PANS clinic that's incredibly well-defined and absolutely research-based, that 40% of their patients had a very clear sudden onset. So we have to let that go a little bit, okay? And they may have had a small flare. We will talk about the different severities and what I really mean by this part. We may have missed it. We may have chalked it up to the terrible threes. We may have chalked it up to a life change. They may have gotten strep and we knew it, but they got treatment and so they got a little better and so we didn't really think about it. So we do not want to miss the patients that someone says, "Oh, Katie's always been a little anxious. Oh, Joe, he's always been a little aggressive. So, it can't be PANS." That's equivocally untrue. So we need to see an abrupt onset or newly worsening of the following symptoms, which are obsessive compulsive symptoms and or severely restricted food intake. They can have one or they can have both. And concurrently with those, they have to have symptoms from 2 out of these 7 categories. Most people have far more than 2. I don't know if it's rare to have just 2, but if you look at the numbers of the preponderance of these symptoms, it seems pretty rare. Um, so, and I'm going to go into all of these in much more detail, so I'm not going to spend a ton of time on them on this sheet. But they can have anxiety and they can have separation anxiety, and then and they will also have tics or handwriting changes, where another patient may have OCD and restricted eating, but have more irritability, oppositional behaviors with deterioration of some math skills and urinary frequency. So some of these symptoms and the severity really fall across a spectrum of how they present and the severity of all of them. So we use this term in the autism world, and I co-opt it for PANDAS. You've met one person with PANS, you've met one person with PANS. There is not a poster child necessarily. There is a definite look, to what that's going to look like. And once you see enough of these patients or hear enough of them, it's not as hard as you think to identify. People always say, "Oh, it's so hard to decide." Well, is it? Um, and these symptoms are a diagnosis of exclusion. A diagnosis of exclusion is simply that these symptoms are not better explained by another known neurologic or medical disorder. Keyword neurologic or medical. So they can have another encephalopathy. They could have another autoimmune disease that better explains these symptoms. And of course, remember, correct diagnosis drives correct treatment. But they can have a diagnosis of autism, ODD, ASD, PDD, all of the different ones, a big alphabet soup of diagnoses. That does not mean that probably the underlying cause of most of them is PANS. Some of them may be a comorbid, but that doesn't exclude them. And there is no age requirement, no matter how many times we say that it starts with the word pediatric. Um, Symptoms absolutely can linger into adulthood, and we have seen adult onset. Especially, this is very clear with our COVID cohorts, where they have the neuropsychiatric syndromes that fit exactly with PANS pandas, and of course the tick-borne illnesses, but we see it with other triggers as well. Some of them may have had soft signs as a child, but even if today they might not have been diagnosed with PANS pandas, it does need further study. We don't have a true incidence rate. There are numbers out there. None of them are all that correct. There was a study a few years ago. It excluded everybody with tics. Over 66% of PANS patients have tics. So wasn't the most reliable study. There's one being done now that's forward faces versus retrospective, so we hopefully will have some more clarification. But our mantra really is it's not rare, it's just rarely diagnosed because we are missing so many patients, which is very unfortunate, which is why we do so many of these talks because we want to raise awareness. We know that more boys than girls have this disorder. That gap starts to close post-pubertal. Not 100% sure why that is. Possibly has to do with combination with more women having autoimmune diseases than men. We know that there's a large family history in the PANDAS cohort. There's 70% of PANDAS families have a history of autoimmune and or strep-related illnesses, which would include acute rheumatic fever of the heart or Sydenham's chorea. So before we go into all the nitty-gritty, let's just think about what's happening to these families and to these kids. You have your baseline, whatever it is. So, like totally neurotypical, on the spectrum, whatever, it's your baseline, it's their baseline. And then one day, one week, over a month, everything is completely different. That is a traumatic event in and itself when the life you knew is no longer gone and you're no longer functional and everything is turned on its end. Um, it's really scary to have these symptoms. OCD on its own is really scary because by nature, those intrusive thoughts are threatening and scary. But then you have a combo of all the other things that are going haywire with these symptoms, with this neuroimmune disorder. You get angry, you can't control that. Your separation anxiety is incredibly acute. You're peeing frequently. You haven't peed your bed, and now suddenly you're 13 years old and you're peeing your bed every night. You don't have REM sleep. You don't, you can't interact with your peers anymore because you've had regression, developmental regression. You can no longer do your schoolwork. You can no longer function at work. And for these parents, I mean, parenting is hard enough. And then your kid, every rule is thrown out. You often can't get any help. It used to be that you'd go to your pediatrician and you would mention PANS. You're like, I've heard of this. And you would get a note within a week from the doctor saying, I'm sorry, I've known your whole family for 20 years, but You mentioned PANDAS, so I'm going to have to fire you from my practice. That's gotten better. And we are having families identified pediatricians actually pretty quickly in some cases, but sometimes the average is you're trying to find a specialist and you've seen 5, 7 doctors. You get accused of doctor shopping at that point. Um, but the pediatrician who's wonderfully identified your child as having PANDAS, they say, but I don't feel comfortable treating it. Or it's really rare, so your kid probably doesn't have it. And so you're left trying to struggle to find help. And in most states, PANS coverage is not covered by insurance. So you are having to deny your child of disease altering, life changing treatments. And we will go into treatments briefly towards the end. Um, and so it's really, really hard. Often one parent has to leave work because the child's too sick to go to school, or parent or adult patients are struggling to get disability. So it's really upending every single person and including the siblings too. The caregiver burden index is higher than caring for someone with Alzheimer's in your home and equal to Rett syndrome. This was a study done out of Stanford. There's other studies similar that aren't in a well-contained, well-supported group where that caregiver burden of index is even higher. There is a clinical urgency because a timely diagnosis and appropriate treatment equals a better recovery rate. This should not be something that's debatable. Um, we don't do this to any other disorder, like, oh, you have cancer. Let's just wait and see what happens. You've cut your finger. Let's just wait and see if we need to give you a stitch. We'll just see. We shouldn't be doing it to any of these patients. We see that onset, we see we've diagnosed them. Let's start treating and taking this very, very seriously from gut go. Okay, now we're going to get into the hows and the whys. Um, with PANDAS, obviously that's trigger is going to be a temporal relationship with strep. That doesn't mean they have to have strep throat that's clear. Sometimes their immune reaction isn't a acute infection reaction. It is the neuropsychiatric reaction. So they're not carriers because they are having an immune reaction. Just their immune reaction is PANDAS. They can have strep throat, of course. Strep is not just in the throat either. It's on the skin, it's on the anus, it's in the gut, it's, in the ears, it's in the nose, places that don't get swabbed a lot. But we also see high rates of mycoplasma pneumonia and other viruses, Epstein-Barr, sinus infections, COVID-19. Then, of course, we have the tick-borne infections. I would just like to note that tick-borne infections in Ohio are at a rate equal or approaching levels in Connecticut. There are too many doctors that say, oh, it's not endemic here. Equivocally untrue. And testing is woefully inaccurate. So we can't just assume because they do a lab cord that they don't have it. So lab testing is problematic in many of these things. There are non-infectious triggers, whether they're triggering it or exacerbating problems. There's something that we must investigate, like mold. Mold can suppress the immune system and create other havocs. This is not a mold talk, but please know can be part of the program. And then psychosocial stress. So when we think of psychosocial stress creating sudden abrupt changes in behaviors, what do we think of? We think of trauma. Um, so for some, it may not be the incitatory trigger, but this is all traumatic, so it may be exacerbating. And then because there's so many symptoms, the cognitive load of these patients is the bucket gets full like that. Just managing to get out of bed, get down to breakfast, and get out the door is emotionally, physically exhausting. And so we're always seeking ways to lower stress at any levels, not just traumatic levels, because stress creates inflammation. And why is inflammation so important? It is the driver for all of this. So what is happening with the disease mechanism? And I go through this briefly. Um, we know that in pandas, there's a 70% rate of autoimmune and strep related. It will not be one gene. Studies are starting to elucidate that it's a cluster of genes, and what that really looks like, it's still an evolving bit of research. But strep enters the nasal pharynx and it starts to activate our immune system. And the strep is a very ancient, very smart organism that's like, I don't need you to kill me. I want to hang out here for a little while. Um, and it evades the immune system. Eventually, the immune system's like, I kind of know where you are, and I am going to send out all these immune modulators and to kill you. We're going to send out our army, and then this is when we get the misdirected immune response with this autoimmune portion of PANDAS or basal ganglia encephalitis, is that the body starts to attack the self, knowing that the strep is somewhere within that nasal pharynx area. And after
Mm,
repeated strep infections that we've seen in mouse models out of Columbia University, the repeated attack of the blood-brain barrier in search of these strep molecules is to weaken the blood-brain barrier, and it becomes leaky. And eventually, the antibodies to strep cross the blood-brain barrier, manifesting in this brain inflammation that causes havoc and ultimately leads to what we see as PANS and PANDAS. And specifically, it's happening in the region of the basal
mm,
ganglia area. And in simple terms, the basal ganglia is the relay station through which neurons control mood, emotion, cognition, sensory, motor movement, procedure learning, and behavior. So we think of it as my computer right in front of me that I'm talking to you all on. And somebody comes over and they're like, let's put a blowtorch to Gab's computer. Fabulous. Because that's what I'm going to do. And part of my motherboard starts to get inflamed. So I may be able to do a few things while I'm trying to put out this fire, but I try to type in Ohio Foundation over and over. And as much as I try, it's not doing it. It's like, nope, sorry, we're inflamed. We're out of order. We're not working. You can try, you can make your choice-based behaviors and
mm,
try them, but we're not doing it because nothing's talking to each other correctly in here. The neurons are not controlling any of this and any of the response. So that's why we see all these seemingly disparate symptoms happening in one patient. Why does this patient have OCD and lability? That makes sense. But then they're banging into the walls, having impulse control, they're having tics, and their handwriting is a complete mess. And oh, and they're peeing their bed at night. Like, how does that all happen? It's really because it's really happening in this whole region that controls all of this. So when we think about what we see in our house, in our office, it's very easy to knee-jerk reaction and say, oh, they're having OCD behaviors, they're having aggressive behaviors, they're having this choice. Um, I urge all of you to change your language and your mindset when you think of this as a behavior, replacing the word over and over again with symptom of a neuroimmune disease. Oh, they're having many symptoms of a neuroimmune disease. These are span symptoms. These are not willful. Because when my motherboard is being burnt by this blowtorch and I'm trying my best, but windows are opening, windows are closing, misdirected responses, the music starts playing, I try to turn it off. I have no control over this motherboard because it's inflamed. It's doing its own thing. It is on shutdown. It's on lockdown. This is what's happening in these patients' brains, essentially. And it can depend highly on severity, of course. So if you have a high severity of symptoms, you're going to have less. If you have a low severity, you maybe control part of your day, but not all of it. But we have to be open to the fact that some of these behaviors are involuntary symptoms of a neurologically based disorder. Okay, so going forward, that's the mindset you come through, and it
mm,
helps us frame how we approach, how we
mm,
treat, how we deal with in the classroom, how we deal with at home, and come through a lens of understanding. Okay. So symptom course. Do these patients have it constantly? Are there breaks? What's happening? There can be single episodes. We know that that's few and far between, perhaps partly due to some of their genetics and comorbid diagnosis, or maybe they're not getting critical care right away. But what is typical of pandas is it's defined by a relapsing and remitting course. So we have an insult, we have, say, a mycoplasma infection, and we have this new onset or secondary onset of these symptoms that go whoosh from 0 to 60 pretty quickly. And then hopefully through appropriate and timely medical interventions, which is rare to get, um, we start to get closer and closer to baseline.
mm,
Healing is not linear. So this line here, somehow need to redo this chart to be more jagged. It is what we call a sawtooth recovery, where we have good days, bad days, good weeks, bad weeks. It doesn't necessarily mean that even though you're on track and you're doing well over a month and getting closer and closer to symptom resolvement, And then boom, everything gets worse. It doesn't necessarily mean you've been exposed to another infection or something like that. It may be part of that nonlinear healing. So our goal is to get back to baseline before we have another flare. We do not always get there. And when we have a cold flu strep season like we're having here, we can live in a petri dish of muck of different pathogens. And so we may not get back to baseline before we're encounter another infection. Some people will just be triggered by strep their whole life, whereas others, it's only bacteria, where we have other patients who are strep, virus, this, that, and you never really know. And you kind of want to put them in a bubble to prevent these infections, but we do the best we can in terms of infection control. And so as we don't have more and more flares and we don't get back to baseline, the picture looks more chronic static. But what we know is that that doesn't mean that these patients shouldn't be treated medically and we should resort only to the psychotherapeutic. And we may need to increase what we're doing. We may need to be pulling in some much more involved medications, which we will get into. So severity can also look different from patient to patient, mild, moderate, severe. These are pretty much based on how we determine the severity for OCD. So 1 to 2 hours a day without debilitating fears is more of that mild picture. So they may do great most of the day, and then 1 to 2 hours a day, things really devolve and fall apart, where we see more symptomatic episodes. So I use symptomatic episodes instead of saying behavior because, again, these are symptoms of a neuroimmune disorder. Moderate is not moderate. Moderate's not like a walk in the park and maybe I'll grab a sweater. It's 50 to 70% of your waking day impacted by all of these symptoms. They may not be fully disabling across all settings. So you may be able to function in one setting or not in another, or partially in one. But school attendance may be impacted, where you do, what your activities are can be limited. And this is a lot. And there's nothing moderate about it. It really feels hellish. And then severe is crisis. Severe is when we have very life-threatening, hazardous impulsivity. Um, we can have areas of where a patient does harm to themselves by just the fact that they have such developmental regression and they're in a situation that they should not be because it doesn't match where they are. They can have extreme weight loss, 10 to 15% of their body mass in a very short period of time due to obsessional food restrictions. But all of these symptoms are impacting 80 to 100% of their waking day. These are in crisis. So how do we get diagnosed? I'm not, because of time, I don't go into a ton of detail about this, but the critical things you have to know are that this is a clinical diagnosis. We get people coming in and saying, my doctor gave me the test and I don't have PANDAS. And I know exactly what that means. It means that the doctor is not PANS literate and they gave them a strep swab. That's all that means. And that they didn't have strep on their tonsils that time. That's all that means. That does not mean that they do not have PANS. Or they may have done a titer and there was low titers. That doesn't necessarily mean either, because we do not chase titers. We have a beautiful toolkit on treating infections, particularly group A strep, on the website. So, it's a clinical diagnosis. So you look at the picture, you look at review at history, you look at medical history, you look at family history, you do draw labs to see what's the functioning of the immune system, what the titers may be, and understanding what's happening in the body. And if we're really having severe symptoms, we may be doing imaging, we may be doing liver punctures, but that doesn't happen that often. So we're really looking at everything and it's a full, complete picture. So they get diagnosed. What are the treatment guidelines? It's a three-pronged complementary mode of attack. First, we really want to turn off the Bunsen burner blowtorch burning my computer. We want to remove the source of inflammation. We want to reduce stress. We want to get out of mold. We want to kill the bacteria, whatever that is. We want to stop creating more fuel for the fire. But when we do that, that doesn't mean our immune system's like, okay, great, mischief manage everything back to normal. We still will have to treat the disrupted immune system. And then we also provide symptomatic relief for those symptoms. So, due to the sake of time, I left these slides in here, but I don't go through all of them. But you want to do monitoring for infection. You may want to monitor the family. You may want to use antibiotics for extended period of times. There's lots of perfectly fantastic evidence to use long-term antibiotics, especially in the case of strep, because of what we know through rheumatic fever of the heart. For some low severity, that's all they may need. Some antibiotics are great anti-inflammatories too. Um, we just want to be careful of using them for a long enough period of time because strep can go from outside the tonsils to intracellular and back. So a short course of antibiotics without symptom resolvement doesn't mean that a patient doesn't have PANS. It means that we just didn't do enough. Um, and then there's the immunomodulatory anti-inflammatory part. So, like I said, the immune system doesn't just go back to normal. We have to tamp down the inflammation and we have to regulate the immune system. And this part is highly dependent on severity and, of course, comorbid health symptoms, because you could have very mild PANS, but a very clear immune deficiency. So, of course, you're going to maybe pull in some more immunomodulatory drugs that you wouldn't might do for some other mild cases. So we really have to look at the full picture. For some, it may be extended courses of NSAIDs, but it may be they need longer courses or other anti-inflammatories like corticosteroids. A lot of these patients have very clear signs of dry arthritis in particular. There's really great research out of Stanford on rheumatology and the PANS patient. Sometimes we don't have a lot of the wet signs, but we have the dry signs, which also can be associated with Bartonella, by the way. Um, and so different modes of treating the inflammation. And then there's IVIG, intravenous immunoglobulin, which is a pooled blood product of immune cells. And you flood the immune system with good immune cells. And it's like, no, this is what we're going to do. Pay attention to us and ignore all the other stuff. So you're flooding them with immune cells that aren't compromised and are going to act correctly. And so they kind of stop the process in the tracks from creating more inflammatory cytokines and pushing out all the bad actors. For some patients, they may need it for a short period of time. Some patients require IVIG for many, many years. However, this is when we have halts in treatment and access. In Ohio, in particular, there is no insurance coverage mandated for PANS and PANDAS. So a doctor cannot provide medical treatment or prescribe medical treatment the way they see fit, that the way they know how to for PANS and PANDAS for their patients. That doesn't mean a PANS patient in Ohio cannot get IVIG or rituximab or other immune modulatory medications. It just means that that doctor has to be savvy enough and in the right type of medicine to be able to fight for their patient and prove medical necessity under a comorbid diagnosis. So we have patients that are getting IVIG under encephalitis, autoimmune encephalitis, or maybe unfortunately lower dose of IVIG under an immune disorder like CVID, chronic variable immune deficiency, or hypergammaglobulinemia, which is another tongue twister. So there are ways around it, but it delays treatment. And sometimes even if there's a preponderance of evidence, that insurance company is still saying no. And it's truly, truly devastating to be told, no, you can't get the medication for yourself or your child. That may be disease altering or life saving. And then there's the psychotherapeutic arm. This is not treating the underlying neuroimmune condition. Yes, there are some psych meds out there that have immune modulatory things that they can that help, but this is not their main goal of them. So really the goal of this is to decrease suffering and elevate adherence to treatment. Not every patient's going to need it. And if they need it, they may not need it for a very long period of time. So with these psych meds, the rule is, because we know in this patient population, SSRI and secondary generation psychotics often lead to bigger negative side effects than other patients. So we have to be very, very cautious when employing these. That doesn't mean we shouldn't do it in some patients. We just have to take caution and start with subclinical doses. And if needed, slowly, slowly titrate up without making knee-jerk reactions to different changes in symptoms because hopefully they're getting medical too, which is changing the whole progress. And remember, if it's sawtooth, they may have a bad period just because healing is not linear. So we always have to be very mindful. And then there's the psychotherapeutic treatment. Um, there's lots of different treatments out there. We may need to do food therapy treatments. Some people may need physical therapy, occupational therapy, but right now I'm going to really talk about exposure response and prevention, which is one of the main treatments for OCD. Typically, we would put a patient in there immediately. And so for those who are not super familiar, I'm just going to advance for a moment to OCD. We have this lying intrusive thought, these obsessions. And of course, it's going to cause anxiety, distress, because it's telling you something very scary and something awful is going to happen, like your mother is going to die if you do this. Um, and so that lying brain says, if you do this, you're going to feel a little better, this compulsion. And it provides a little bit of a temporary relief. However, OCD is like, nope, nope, nope. I'm ruling it. I'm the main brain right now. And you didn't do it well enough. You need to do it again. You need to keep doing the compulsion because you're still thinking that. So therefore it could still happen. And it can still happen. It can still happen. So ERP is designed to expose you to that obsessive thought and break the cycle here at compulsion and teach patients to live with the discomfort of not doing their compulsion and not making it stronger. However, with our PANS patients, let's go back to that basal ganglia and this burning computer of mine, where there is little, depending on severity, choice-based control in some of, right at this point, that these neurons we are not having the appropriate response to impulses. Um, and ERP is nothing but a choice-based behavior program where you're making the choice to say no to the compulsion. So we know that if you delay it until medical treatment has at least begun to help. We may not get them back to baseline at this point. Doing some therapy may be part of getting that patient back to baseline, but we're not starting it right away. And we are approaching ERP from a different lens of understanding what's happening neuroimmunologically with these patients. Because trying to say no to something that you can't control, your brain, you don't have a lot of control over, it is re-traumatizing and can make patients more likely to not adhere or want to go later when they are medically more stable to do it. So we know it might get a little worse, but we have to do that. So it's a definite paradigm shift of how we think. And we carry this over into how we approach school and all of that. So with all these different medications and who we have in our area, who we can see, we may have a very large circle of care. Sometimes the unicorn is a one-stop shop doctor that can do the medical and do some of the, do all parts of the medical. It's hard to get that. Sometimes we have to cobble together a full team. So I'm going to go into symptoms. And this part I do fairly quickly. We're at 12:38, so I definitely have to go quickly. So OCD, very importantly, we think of compulsions as some things we see, hand washing, lining things up. Please, 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 please be mindful that a lot of these patients have internal compulsions, mental compulsions. You may not see them, you may not be aware of them. They may be pulling you into part of them if they're confessing, needing reassurance, doing things like that. But they may doing a lot of the reviewing and mental checking in your head. So we may see just the anxiety. We may just see the anger about how stressful it is and not really understand right away that this is OCD driven. Restricted eating, fear of very heavily based with OCD, fear of contamination, vomiting, choking, ritualistic eating, but it can involve sensory issues, decreased appetite. You can have a diagnosis of ARFID and diagnosis of anorexia. Anxiety, of course, you're going to have anxiety with the OCD, but what is hallmark is very, very critical separation anxiety. This is one of the biggest things that we deal with. So we don't want to leave mom. We don't want to leave the house. We're terrified to. That OCD is saying, if you leave your mom, she's going to die. If she's going, or there'll be a car accident, or no one will like me, or I will never ever be able to sleep again, or I will choke on my food, or whatever it is. It's really scary. And sometimes being close to a certain person in our house can feel reassuring. And so this is a huge thing that these families are dealing with on a day-to-day throughout the night basis, kids sleeping in their bed, everything like that. Aggressions, defiance, and rage is in about 62% of patients. There often we cannot find the antecedent because again, this brain is misfiring. Sometimes they have a 6-hour rage come out of it and not remember anything about it. They may feel remorseful or not remorseful. They're like, well, I don't even know what happened. So what am I being sorry about? But that doesn't mean if they knew what was happening and understood, they wouldn't. So, and then there's behavioral aggression, which can manifest in different ways, baby talking, sucking your thumb, watching toddler shows. But in the day-to-day base life, it means we're not able to necessarily associate with our peers the way we're used to. And this contributes to social isolation. Learning difficulties include a whole host of things like math skills, decreased in executive functioning, which is one of the things that often is hardest to get back to baseline for many years. Memory loss, visual spatial, poor concentration, impulsivity. This is very important because impulsivity is part of that very dangerous part where self-harm can get involved when we think of those patients in severe crisis and short-term memory issues. We see fine motor skill deterioration where handwriting completely changes. It can be very obvious, but it can actually be more subtle. We can say visual spatial abilities are reduced. We have tics, both simple and complex. I still find tics very hard to identify in some kids and adults. Like it can be a squeal or a cough or a grunt or a throat clearing, and you're like, oh, they just have a little, must have a little postnasal drip, but it may be a tic. Then, of course, the complex tics, they can have a diagnosis of Tourette's. They can be clumsy. They can have choreiform movements. There's a good video about part of the diagnosis using looking at piano fingers, um, which are really small movements that are different than the big movements we see in Sydenham's chorea. There can be issues with sensory integration. Sleep problems are a major problem. We know that OCD plays into that with long time bed rituals, but we also have night terrors, night wakening. 3 studies out of Stanford of the decreased REM sleep, especially during that high flare with lots of inflammation. Separation anxiety, urinary symptoms. If you see sudden onset of urinary symptoms or sudden onset of OCD, you need to immediately think PANDAS. Immediately, like it's basically pathognomic. But we can see secondary urinalysis. Urinalysis is typically normal. This isn't like having a UTI in the elderly, which we immediately think of patients who suddenly act a little off in a nursing home. The first thing you do is test for a UTI. Okay, so this is an overview of PANS and PANDAS. I'm going to go through some of talking about self-harm a little. There aren't a lot of research-based papers just on suicide thoughts and behaviors and PANS. There are some mentioning it in all the characterization papers, but back in 2023, or a group from Sweden, SANE, did a survey. And, you know, from my anecdotal evidence, for whatever that's worth, I was like, oh, yes, yes, I see that all the time. So they interviewed 240 respondents, mostly parents and caregivers, not really looking at the adult population. And 51% of them reported intentional suicidal attempt or behaviors. What's really striking about this data is the age. The very young age of the respondents is over half below the age of 15, really close to half being under the age of 11, and even having some as young as age of 7. I talk to hundreds and hundreds of families every year, and I know the age is younger. I've heard 5. I know I've heard 3, but I don't even process that because I think it's too emotionally tough to hear that from about a 3-year-old saying that. So, you know, no matter what, even if they don't make an attempt of any kind, this trauma about this is happening at a very young age and must be taken so importantly. We cannot dismiss this. This is a trauma and a thought, and it's shaping these children's lives and what's happening as adults. It's just as important, and more research needs to go into it. What we have to really know about what the respondent said is that, of course, much of it was linked to obsession and compulsions and that whole subcategory of OCD, of self-harm OCD. But we have to look at a bigger lens because we know from the results and what we talk about all the time is that included in those harm related thoughts are discussion of severe distress, hopelessness, and social isolation. As I talked about these symptoms, very briefly, and the severity and the relapsing remitting nature or the chronic nature of this disorder, the more and more we have these symptoms and, not always being able to access care, that can drive distress, that can drive hopelessness as we're further and further, impacted by these symptoms. It creates more social isolation. We cannot just thinking about self-harm in a bubble without them. And so, among the reporting of no intent to self-harm, we know that there were able parents were able to stop attempts of self-harm. And you're like, wait, how does that make sense? So there was no intent, but they were doing it anyway. That really speaks to the impulsivity that is at heart of a lot of these PAN symptoms, especially at the crisis mode. So they're not planning anything. They haven't thought of a plan. Very importantly, they haven't eliminated a plan. And we all know when we talk about assessing, we talk about, do you have a plan? Have you eliminated? They haven't even gotten there. But these are impulsive. They can be, not everybody, but they can be impulsive acts with little to no planning. And then others have threatened to, but not necessarily even with a plan. And it can be part of that impulsive thing. We also know that the rates between genders is negligible. There really isn't. It's not more boys than girls. So we need to be looking at the whole thing. So how do we take these clinical implications and as we look at and assess for risk? We have to start off with the tenet that self-harm and suicidal thoughts may be a part of the neuropsychiatric presentation of PANS. So, like I said in the beginning, we do not want to assume just because we don't see anything, they're not saying anything at the moment, that that threat isn't there. It is wiser and safer to start with these assumption that we need to be carefully monitoring. We need to recognize the signs very early and looking at all the signs and do our best to coordinate medical and mental health care together because we can't just look at it in a bubble. We can't just say, oh, they said something, so therefore the risk is really high. We need to look at it in the lens of OCD self-harm. We need to look at it the lens of how severe are they and what's happening with their impulsivity. How long have they had it? What kind of distress are all of these symptoms, whether a new onset, later onset, chronic, is causing them stress and anxiety? How overwhelming is their anxiety? Um, how overwhelming is their self-isolation? Do they have hopelessness? What is that level? And really, and remembering that it can be very early onset for these thoughts and behaviors in kids. So we're not just looking at the teens. We're not just looking at the adults. We have to be looking at all ages, from 3 up. And so I really appreciate being part of this talk today so that it is part of the thought process that when we look at these patients, when we look at our family members, we don't carry that through every discussion, but we always have to be mindful that there is a risk of this and what are we going to do and how are we going to escalate care, both medically and therapeutically. In Ohio and across the nation, we at Aspire have what we call chit chats, which are not professionally led. There's no therapist there, no doctor. They're all parents and caregivers, or we have a separate one for adult patients, where we call them chit chats. They're just basic peer-to-peer, parent-to-parent support groups. We have one for Ohio. The link is here. That's once a month. That one, I think the first Wednesday of the month. That one's consistent. The adult patient is actually consistent too. Every second Tuesday of the month. But they're all up there. We ask people to register each month. The Zoom link changes. Um, really there to create community, to provide a little like, oh, you can get through this. Or sometimes we ask like, oh, do you have a good immunologist? And go to that one. Oh, don't go to that one. Or, well, if you go to that one, you have to fit this profile because they only see this kind of patient. Sometimes we're able to provide that information. It's not there to give medical advice. We talk about some of the things that we've done. Um, and usually they're small groups, which I love. People are like, oh, but not that many come. I'm like, oh my God, if 5 people come, that's fabulous. Like, that's great because we get more and more time for everybody to really talk and share. Um, and so that's available. We also have a Facebook group, which I didn't put in here, for adult patients and families. It's not for caregiver, medical people or school district people. We want to keep it as safe a place as possible. So just some key takeaways. These are neuro and psychiatric differences, and they have to be treated differently than pure psychiatric, if that exists. Patients can get better, but early recognition and timely matter treatment can help. But not all hope is lost if we catch it many, many years later. It's a clinically diagnosed. Um, the symptoms, how they present, and the severity really show up on a spectrum. So again, you've met one kid with PANS, you've met one person with PANS. Um, it can take a multidisciplinary team to treat, but that's difficult. There's so many roadblocks to diagnosis. I didn't get to really go over that too much today, but there are. It's not rare, it's rarely diagnosed. And some of those big red flags, even if we're not comfortable diagnosing, if a patient has enough red flags, please don't hesitate to say something. Say, maybe you need to talk to somebody else about this. Maybe you need to go to Aspire and look at what they have about what the symptoms are. Look at the symptom rating charts. Look at the symptom tracking charts that they have available, and educate yourself more. And maybe that's something you should look into. Um, but these conditions may be common, much more common than currently recognized. So please keep ruling in medical when we're looking at these patients. I'm going to end my slideshow and stop sharing. And you have a few minutes for
That was
questions. And of
incredible,
course, we can be
Gabriella.
emailing to the best. I'm sometimes slow on some of the responses. So, um, but I do get to you, I promise.
That was so informative. Thank you so much for that overview. I know it was fast and furious. I do have looks like 3 questions that have come through, so maybe we can start there and see
Yeah.
see
Oh,
where we get. So the first one is about the prevalence of these disorders. How often are patients misdiagnosed?
I mean, like we don't know the exact prevalence, but I don't know. I just know it's a lot.
Yeah.
Um, Years ago when I ran the PANS, we had just finished up right before I became president. There was a survey from all of these people who had come to a conference. There were about 300 people and were in attendance. And back then, so that was 2013, 14-ish, people had gone to at least 6, 7 doctors before getting diagnosed. That was an average. That means there was much more. Um, and most of them were out of pocket. So at a certain point, you give up because you can't afford it. So by attrition, there's just going to be that. And then, of course, if you have a doctor that's like, oh, well, we gave you 5 days of amoxicillin, your kids didn't get better, so they don't have it. So then the we almost got there, but we don't get there all the way due to lack of complete understanding of how to diagnose and treat this disorder and the misconceptions therein. And then there's huge populations that are being missed. It is not an equitable disorder. We still have doctors saying, oh, well, Black people can't get this disorder, which is unequivocally untrue. That's just not what you're seeing in your practice. Um, Dr. Delaney, who was with Columbia now in his private practice, she did a study looking at the numbers of psychiatric hospitals in New York State and what percentage of those had a tick-borne disorder. I wish I could remember the number, but it was astronomical. I mean, it was more than clinically significant. Um, so and tick-borne diseases are at an endemic level. We know COVID level was a whole pandemic. So we know that things happen and are happening, and we're at a more of a toxic burden situation. So more and more people are going to have this, and more people are unfortunately going to get missed until more education is done on it.
Yeah, that makes sense. Thank you. I have two questions from it seems like parents that may be experiencing
Yeah.
PANS or PANDAS. So the first one, they said that their son had a tonsillectomy after frequently developing strep, and shortly after the surgery began experiencing motor tremors that only occur when he moves his hands or legs. They've had a lot of tests done, but they're wondering if this could be indicative of PANS or PANDAS.
Okay, so the tonsillectomy, adenoidectomy is a really interesting topic. So for some, that um, is one of the treatments
Mm.
is if we're having those repeated strep infections, do we or do we not? And what do we do after that? So there's some doctors like out of Georgetown. Um, he does Earl Harley, he's done most of the research on TNAs. And it's kind of a 50-50 almost, maybe a little bit more in favor of having them, but he really would prefer for all of his patients to have the tonsillectomy, adenoidectomy with courses of antibiotics before and after, with anti-inflammatories that don't cause more bleeding before and after, but then within a month or so getting IVIG so that we're really flooding the immune system with good immune system. So for this woman's son or grandchild that has had tremors and tics after, that really, I mean, sure, I personally, I mean, I cannot diagnose and say, oh yeah, of course it's pandas. It really could be, and it's something worth looking into because when we remove a tonsillectomy or an adenoids, we can release bacteria. We can also disrupt our mast cells, which is a huge other portion that I couldn't get into, but mast cell disorder can cause a lot of these same type of symptoms. Um, and we can see, and then it can alter how our immune system is ultimately working. So if you take out the tonsils, well, that are sort of a trap for these bacteria, where's it all going and what's happening? So we can see an uptick of symptoms after a tonsillectomy too. But it may be why, back in the 50s or 60s, 70s, tonsillectomy was like, I mean, every kid had
Mhm.
one. And I remember talking to very old pediatricians, and they were saying, oh, yeah, back in the 50s, 60s, we called that the strep crazies. Everybody got crazy after strep. They may not have been full-blown pandas, but they're like, yeah, everybody knew that. And that was like one of the reasons to get rid of them. And that may be part of the picture and part of the whole historical evidence of what is happening.
Yeah, that's fascinating.
Yeah.
We have another question from a parent, and I might connect you directly with Caitlin because she's looking for specific resources in a specific region.
Yeah.
But she did say when her daughter's insurance requires a referral, how do you go about getting one when she's not being heard by the physicians and she doesn't want to be accused of doctor hopping?
Right. It depends. So one of my answers is tell them to like take their, just assume that you're not going to find one. That
Yeah.
is referral work, like because you can't really get a referral to a doctor who's self-pay. And sometimes you have to do everything you can to get to a doctor that's self-pay. It depends on what region you're in. There may not be a insurance-based provider in your area. But say we're going to go down the insurance-based provider area. There may be one, and that would be fantastic. And then we put that to you. Um, but then sometimes the approach is not coming in full guns blazing, go, I want to talk about pandas, test my kid. I think they have it. Doctors don't always love that. Love you all doctors, but a lot of you don't love that. And so sometimes posing things in the form of a question and posing them in terms of a timeline. I advise anybody, no matter the doctor they go to, is write your timeline. What started when? Do you know if there was a precipitory illness or a precipitory something? Did you go camping on lake whatever and we were in this old cabin and you smelled the mold so badly in front of it? You're not going to have a conversation about mold with an infectious disease doctor from a major hospital. They'll laugh you out of the room. And that's okay because that's not their wheelhouse. We cannot expect doctors to not work in their wheelhouse. Like you would not break a leg and go ask your gastroenterologist to fix your leg. You go to the doctor that's in their area. So that's also a really important thing. So sometimes you just frame in the question and say, look, this is what's happened. It doesn't make sense. I know we're looking at a lot of psychiatric issues, and I'm fine talking with a psychiatrist and being open to that, even if you may not be, um, and saying, but I know my kid and I know like this is new and there's all these medical things happening and they're peeing all the time and look at their handwriting and look at this margin drift and bringing as much evidence of what you see and making yourself an equal partner to the best of your ability in a non-threatening way.
That's great. All right, Bessie, Sarah, Jamie, Gabrielle, I'm afraid we are out of time to answer your
Yep.
questions, but I will send Gabriella's email in my recap email so that you can connect with her directly and get your questions answered.
All right. Thank you
Um,
so much for having us. We
yes.
really appreciate
Oh my
having this
goodness.
conversation about this, which is so important for our
Absolutely.
entire community.
Thank you all so much for joining us today. I hope you all enjoyed the session. And as a reminder, that follow-up email will have the link to the recording, Gabriella's email, the slides, and the surveys for your CEs. One final note I want to share is next month during our webinar, we are going to be discussing AI and suicide prevention. Our webinar is going to look a little bit different. So on March 4th at 1 o'clock, we're going to be doing a national online conversation with thought leaders, policymakers, mental health professionals, trying to bring everybody to the table and talk about how people are in distress are using AI, and then what can we do about that to make sure people are staying safe. So that will be on March 4th. I'll send the link to register if you're interested. I think that's all I've got. So thank you all so much for sticking around with us for the full hour. This was so informative, Gabriella. I
Thank
can't
you.
thank you enough for
I
being
really
here.
appreciate it.
And we've got to continue the conversation. So thank you all
Absolutely.
and hope you have a great day.
Thank you. Bye.